limit the number of people joining from one gathering place and practice social distancing. And with that, I will turn it over to Dr. Hoop.
Okay. Thank you. Good afternoon, everyone. Welcome to the fifth series. Today we'll be discussing critical care in the scope of ICU and beyond. So what happens when you're dealing with a critically ill patient outside ICU? Just as a note, today we'll be dealing with concepts which I think for a lot of us in our hospitals in Zambia, these are things that we don't discuss, and it may be an area which is not familiar with a lot of us. So what are we hoping to achieve? By the end of our discussion, we want to define the critical care continuum of care. We want to understand the goals of the oxygen saturation are when you're dealing with a critically ill patient in medicine. So what are your goals of oxygen therapy? We want to define and utilize some scoring tools. What is going to help us define what a critically ill patient is and what interventions are we going to put in place? We're also going to outline some of the life-threatening signs and symptoms which indicate time critical care is needed. We'll look at the personnel in a hospital setup who are responsible, who should we call upon, and what expertise do they bring to the table? So identifying the key personnel, this is critical. If time allows, we'll look at how we can create or review a rapid response tool, a policy tool, which is easy, which can be easy to implement in our departments and in our hospitals. And lastly, we'll look at the importance of simulation scenarios and identify some of the gaps which may be present in our hospitals using the SEDA approach. With me here, Sarah has already introduced Dr. Papytcho from Livingston Central Hospital. I also have Dr. Ndava Spuka, another critical care physician who is with us. So I'll get the ball rolling. Today, our patient is a 54-year-old male who comes to us with a history of coronary artery disease. He is hypertensive with type 2 diabetes and is admitted in the inpatient ward 3 days now with COVID-19 infection. So all the discussion will be related to this patient that we have. Okay. So as we begin our discussion, I'll invite Dr. Papytcho to just define critical care and intensive care. Just before he begins, we always get this question: what is the difference between intensive care? What is critical care? What is high care? What is high dependency care? And are they the same? So this question keeps popping up. Indeed, some people say critical care or ICU is scary because of all the machines which are involved. I hope that Dr. Papytcho will debunk some of these myths as he tells us more about the critical care continuum of care. Dr. Papytcho, please.
Thank you very much, Dr. Hope. Good afternoon, all participants, and welcome to today's session. Before we go into answering Dr. Hope's question, there's this poll that I would like our participants to drop the answer in the chat box. As you can read it, the question is, which of the following are considered critical patient care? 1, is it early recognition, assessment, and decision-making for deteriorating patients? 2, rapid and timely intervention for patients at risk of clinical decline. 3, identification of clinical warning signs prior to cardiac or respiratory arrest. 4, providing expert assistance in response to consent for a patient status. Or 5, or the above. Quick, you pick one and then you drop it in the chat, and then we continue for our discussion about differences between critical care and the intensive care unit, and some more discussion to follow. Sarah, please, can you check the poll?
We don't have any responses in the poll yet.
Okay, I guess they're still reading. I'll give them 15 seconds. Anything has come to Sarah?
Nope, we still don't have any responses.
Okay. Maybe for the interest of time, we can just discuss the same question together with the participants. So when you check at this question, you find that all of these answers, if you put them all together, they kind of give you exactly that what is a critical patient. So I would say all of the above should be the best answer. Congratulations for those who chose all of the above, because altogether they really define critical patient care. So, as Dr. Opp said, what could be the difference between critical care and ICU? The critical care, it's not really a place in the hospital. It's all the time at which you act in a process of illness of the patient. Once you happen to pick up a deteriorating sign in a patient whose condition is being managed in the ward or elsewhere out of hospital or anywhere, at the time that the condition has been picked, that should be considered as a critical care. So it's a critical time at which it needs rapid intervention to optimize patient condition to be best. But when you look at intensive care units, that now it's a place in the hospital, or whether it's a ward where patients with threatening or established conditions are taken for different reasons, either life support or monitoring, or one of the two, or both. So you find that the patient in the ICU, they could also present, while being in the ICU, they can also present a critical care condition whereby it's being identified there and then you act immediately. So in short, we say critical care, it's all about time of identification of the patient process condition. And when you look at this statement that is posted just below this question, a patient whose condition deteriorates acutely while hospitalized often exhibits warning signs. So those warning signs, those are the signs that will let you say, no, my patient is now critical. It might need ICU type of care. So that's a big difference that we can pick between ICU and the critical care. Dr. Should we go further?
Yes, Dr. Papytcho, you can.
Okay, so if we want to proceed on, it's whereby come now the concept of continuum of care. What is the meaning of continuum of care? A patient who's critical, you've picked the deteriorating signs. The place can be either in pre-hospital or within the hospital. In pre-hospital, meaning out of the hospital, it can be everywhere, at home or in a public place or any place where you picked up the condition of the patient that needs immediate attention. So that patient is usually taken care of either by people who have been trained or even non-trained medical personnel who are able to offer emergency medical services like first aid. So after identifying what matters in the pre-hospital situation is to have a better communication facility so that you inform a receiving institution on how the condition of the patient is and how you are going to take the patient and what time the patient will arrive. So that at the receiving institution, where it could be now in the pre-ICU, but in hospital, you have a team that is prepared just to continue up with the continuum of care. So that team is prepared to receive the patient who's coming and being briefed exactly the condition of the patient. The team will have everything that is needed for them to continue with care. So the challenge that we get in the hospital, it's patient has been, the care of patient has been really fragmented in the sense that we've got different groups. This one will come and say, me, I'm just a surgeon, me, I'm a physician, me, I'm an obstetrician, I don't look at this, I'm pediatrician, whereby by the time you look for the person who's ideal to look at the patient, it might take long and then compromise the patient's general condition. The other challenge is poor communication and lack of collaboration between the separate units. That makes it again difficult to have a continuum of care. So this is all about having a rapid response team or rapid response system. When this is established, you'll find that there will be a better collaboration, a better establishment of a team that is ready to act and intervene whenever the patient is needed. And for those patients who's already in the hospital, they can now be a stage whereby they need to go now to ICU. So when it comes to ICU type of care, in the ICU, as it was said, condition that has been identified, type of care that is being offered, what matters there, as you are giving the care immediately, you are also thinking at the post-ICU condition. You want to give a patient better condition when they go home. They should have a better type of care, better type of life after discharge. So for that, you avoid premature discharge, because if you discharge your patient prematurely from the ICU for different reasons that I will not be able to mention here, there's high risk of readmission and mortality, okay? And at the time of discharge, you have to avoid discharging patients late in the hours whereby there's no one who would look at those patients either in the ward or in the other part of the hospital. So the discharge should be really well timed for better care to be continued after the patient has come out from the ICU. Imagine you've done all that great work, and then patient, when being discharged, facing such a condition whereby it goes and deteriorates and maybe loses his life. Another point is good communication. When discharging your patient from ICU, you have to give a better summary to the patient who's going to take care of the patient so that they know what you did and what type of care they should continue with in the ward. Okay. Dr. I think, unless if there's any more to talk about, I think I've given enough on what I had to say about critical care and ICU, especially talking about the continuum of care.
Yes, you have, Dr. Papytcho, thanks. Would you like me to go ahead?
Please, Karen.
Okay, all right, so thank you very much. To continue our discussion, we'll look at this case example. So you are the healthcare worker, you're working in a rural hospital. The nearest hospital to you, which has an ICU, is about 90 kilometers away by ambulance, but it's the rainy season, so the roads are closed. So the history is that earlier on in the morning, during your ward round, you saw the 54-year-old male that we've talked about, who has a history of coronary artery disease. He's hypertensive with type 2 diabetes as well. And he has been on our ward for 3 days now with SARS-CoV-2, pneumonia. His chief complaint is shortness of breath, But earlier on in the morning, you noticed that he was slightly tachypnic. The respiratory rate was 27 breaths per minute, but he was still able to speak in full sentences. He was on oxygen at the time via nasal prongs at 3 liters per minute. And when you examined his chest, you found that he had a few crackles on his lung examination. Otherwise, everything else seems okay. Because you're a good healthcare worker, you took his vitals, and this is what you found. The respiratory rate is 27 breaths per minute. The temperature is currently 37.9 degrees Celsius. The heart rate is at 95 beats per minute. The non-invasive blood pressure is at 107/59, and the SpO2 is at 92%. Remember, he is on oxygen via nasal prongs at 3 liters per minute. So, class, looking at the vitals of this patient, how would you interpret your patient's vitals? Sarah, can you please click on the link? Okay, so in critical care, you cannot treat a patient without knowing what the vitals are like. The vitals are the clinical signs and tests that we do on the bedside, which give us an indication on the physiological state of the patient. Vitals which are being beamed at the moment, these are the normal ranges. We have our temperature on average 37, but we know plus minus 1, so 35.5 to 36.5. Our heart rate, about 60 to 90 beats per minute. Pulse, which is the same as our heart rate. Our BP, 120/80, even though in critical care, we like to talk about the MAP, the mean arterial pressure, which should be between 60 and 90. In a normal adult, we consider the normal respiratory rate to be between 12 and 18 breaths per minute. And of late, with the advent of COVID-19 infection, you cannot talk about vitals in a patient with COVID without checking your oxygen saturation. So typically, you want to have a value above 96 or above 95 in your patient. pH is also a good indicator of the metabolic status of your patient. So a pH of 7.3 to 7.5. This is just very arbitrary. We know that there are a lot of conditions which will cause a skew in either direction. Sarah, we can go back to the main presentation. So going back to the question, Sarah, can you scroll down, please? Okay, thanks, thank you. So looking at this patient's vitals, our patient's SpO2 is at 92% on 3 liters per minute of oxygen. We're told that the update is that on 3 liters per minute of oxygen, the patient's SpO2 has dropped to 86%. When you reassess him, he appears to be more tachypnic and is working harder to breathe, meaning he's laboring, he's using his accessory muscles, and this time he can only speak 2 to 3 words at a time. So class, I just want you to click in the chat box or for you to make a comment. What do we think of the condition of this patient? Is he improving, or is this a patient who needs care and his oxygen delivery to be escalated? A quick comment in the chat box. Okay, so I don't have any comments at the moment, so I'll go ahead and we'll talk about oxygen delivery in patients who are sick, medical patients in our ward. Oh, thank you. Muviana has given us a response. Muviana says, okay, we do have a lot of responses actually. Yeah. Thank you. Thank you for everyone who's made the effort. Everyone says the oxygen therapy needs to be escalated because the patient is getting sicker. And you can tell that at this point, we have not used any sophisticated machinery to talk about the patient's conditions. just the vitals, and also the clinical picture of the patient is telling us whether the patient is improving or not. But we come to the most important question. How do you titrate your SpO2 goals in a patient who is sick, in a medical patient? How much oxygen do you give? Is there such a concept as too much, as too little? And what parameters do we use? If you remember, in our earlier sessions, we talked about the fraction of inspired oxygen, which is the amount of oxygen we give via different therapies. For today, we'll talk about the target saturation of in adult patients. Sarah, can you please click on the link? Okay, so this is just this article is from the British BMJ. It talks about oxygen therapy in acutely ill medical patients. So this is an analysis of several studies which has looked at the outcome of patients who have been on auto. So acutely ill medical patients. This is the population of patients who were being studied. So this was a systematic review and an analysis of various studies over in 2019. So what it showed is that sometimes we give too much oxygen, and giving too much oxygen actually increases the mortality for medical patients in the hospital. I'll go through this slowly so that we all understand how this may happen. Traditionally, and in previous lectures, we have talked about administering oxygen to patients who have low SpO2s. It is the norm. We give supplemental oxygen to patients who are desaturating. However, when you administer oxygen, this has to be titrated against the saturation of the patient. What this study found is that for acutely ill medical patients, the recommendation is a target of an SpO2 of 96%. So you do not aim for a saturation above 96. At 96% SpO2, you could be happy with the oxygen therapy. We'll talk about the physiology in a minute. However, then there is another subpopulation of patients with coronary syndromes, patients with acute strokes, patients with acute MIs. For these patients, the recommendation that you do not initiate oxygen therapy unless the SpO2 is below 90. So your target is 90% of the SpO2. And in this recommendation, there were two sub-recommendations which were made. One group strongly recommended that you want to target on SpO2 of 93, while the other weaker recommendation was a target of 90 to 92 of the SpO2. However, what the study concluded is that it is reasonable for an acutely ill medical patient to target an SpO2 of between 90 to 94 for most of the acutely ill medical patients. However, in medicine, we have another subgroup of patients with COPD as an example, or patients who are at risk of developing hypercapnic respiratory failure. For this population of patients, you may have to actually lower the guiding SpO2. You may actually be happy with an SpO2 of between 88 and 92%. So what is the physiology? Why are we lowering our targets? Why are we, as I like to say, why are we happy at a lower SpO2? When you look at our lung physiology, there are a lot of changes and there are a lot of effects which happen in the lungs when pure oxygen is administered to patient. So I'm not going to go into the details, but we know that we have hypoxic pulmonary vasoconstriction, and this results in a VQ mismatch. We also have the Howden effect. All of these may cause oxygen-induced hypercapnia, and this may lead to respiratory failure, especially in patients who depend on a hypoxic drive to drive their ventilation. So always have to be worried in this subpopulation of patients. So a lot of our patients who have severe hypoxemia are the ones who are at most risk of this. A lot of patients would be a lot of these patients would be relying on this hypoxic drive to drive their ventilation. Therefore, it becomes important to titrate our oxygen saturation in this subpopulation, COPD, hypoxic drive patients. You want to titrate their SpO2 between 88 and 92%. So remember, the key physiological phenomena that we're looking at is our hypoxic pulmonary vasoconstriction. Thank you. Sarah, we can go back to the main slide. Okay. If we have any questions on this phenomena and on these targets, please feel free to drop questions into the chat box. However, all of this material that has been discussed so far is available on the Learning Resource Center. After the lecture, I encourage you to go to the Learning Resource Center and look at some of these studies and look at some of these practice guidelines, which are on the Resource Center. Okay. At this point, I'll invite Dr. Spooker. Are you with us? Sarah, sorry, Sarah? Yes, you can just pause there. Dr. Spooker, are you with us?
Hi, Dr. Piri.
Hi, how are you?
Fine, thanks.
Okay. Are you able to take over on the patient update and we look at the differential diagnosis before you go into the scores? Is that okay?
Sure. Yeah.
Okay.
Thank you.
Okay, thanks. Sarah, just scroll upwards a little bit to the last paragraph. Just there, thank you.
Okay, thank you so much, Dr. Papytcho and Dr. Piri for the discussions, clear discussions so far. So I would like to update on the new vital signs for our patient. So the respiratory rate is now at 32 breaths per minute, and the temperature is at 39 degrees Celsius, and the heart rate is 115 beats per minute, and the non-invasive blood pressure is dropping. It's at 83 over 55 millimeters of mercury, and the oxygen saturation has dropped further down to 86%. So as you can see from the clinical course of this patient so far, at this stage, you can clearly see that there's something going wrong with the patient. The patient's clinical condition is deteriorating, as evidenced by the vital signs above. So this will bring us to the next session where we'll be talking about the use of clinical scoring systems. So we'll be talking about a few of the more practical scoring systems that have been devised by different schools, and most of them have been very, very helpful in improving our patient outcomes. So Sarah, before I go into the details of the clinical scoring systems, I would like you to scroll up. Okay. Okay. Okay, no, scroll down, sorry. Let's get down the case. Yeah, up. Yeah, up. Yes, down again, sorry. Take me down. Down again. Sarah, you've gone really, really far. Let's get back to the original slide. Yeah, keep going. Yeah, keep going. Just there, just there. Yeah, so our practice change action items as we proceed to the next session will be to define and use the QSOFA the Muse, and the QCSI. So I'll briefly define all of these as different scoring systems. But just before we do that, I would like us to review the question below. Sarah, just scroll down a bit. Yeah, just give us that question. Okay, there. Yeah, so looking at the patient so far, which of the following are possible differential diagnoses for the signs and symptoms that the patient is presenting with so far? So kindly look at the options and give us your thoughts by dropping your response in the chat box. So give ourselves, I think, roughly about a minute so that we can see what your possible differential diagnosis for this case so far look like.
Eso. Está fuera. No.
Okay, I think in the interest of time, I think we have a few responses. Sarah, you can just show us summary of those responses. Okay, well done. So we have the following options. So the question is, which of the following are possible differential diagnosis for the case that we have with the clinical signs that we have so far? So sepsis, looking at the presentation and some of the signs and symptoms as well as the vital signs, it's possible this patient could be having sepsis. SARS, which is systemic inflammatory response syndrome, it's possible also looking at the manifestations, looking at the vital signs of this patient, the temperature and the like, this patient is likely to be having SARS as well. Respiratory failure, it's also a possibility. ARDS is also another possibility. So congratulations to those who considered all these as potential differential diagnosis. Thank you so much. Well done. Yeah, so so now we'll go into details where we'll look at the various clinical scoring systems that have been devised that various health centers and facilities are actually applying. These clinical scoring systems have been shown to improve clinical outcomes because they act as triggers, as alarms at which various interventions can be instituted. So some of the scoring systems that we have will include the QSOFA. The QSOFA is a quick sequential organ failure assessment. So I'll be talking about this in detail briefly. And then we have another example of a scoring system, which is it's called the Muse, the modified early warning scores. And then we'll also talk about the QCSI, which is the quick COVID-19 severity index. There are so many different types of scoring systems, but in this particular session, we'll just briefly talk about the three. So when we talk about the QSOFA, which is the quick the quick sequential organ failure assessment. This is a simple tool with various parameters, bedside parameters that can be considered. And then each of those parameters is scored, given a score, depending on the value that is obtained from the patient. And then a total score is calculated. And then depending on the score, there are further guidelines that should be followed. And that guideline will also give an indication of what sort of response or reaction or intervention that needs to be instituted. So the higher the score, the higher the risk of deterioration of this patient. So when you look at the QSOFA, more specific, this scoring system identifies patients at higher risk of in-hospital poor outcomes, such as mortality or long hospital stay. So this is a modified version of what has been used so far, which is just the SOFA, the SOFA without a Q, the sequential organ failure assessment. This tool has been used in the context of sepsis or a patient with presumed or confirmed infection. And the SOFA is used in an ICU setting because it has got more parameters that are considered. So for more details, again, I'll quickly refer to our Learning Resource Center, where you access most of this literature. So the QSOFA actually is a bedside tool that only has 3 parameters. So you talk about the first parameter is altered mental status. So as you examine the patient, you'll see that there's an acute reduction in the Glasgow Coma Scale. The other parameter, it looks at the respiratory rate. And then the third one is the systolic blood pressure. So you're only looking at 3 bedside parameters. The first one is the altered mental status of the patient. So you'll be looking at the Glasgow Coma Scale or the conscious level of the patient. The next one, you're looking at the respiratory rate of the patient. And then the third one is the systolic blood pressure. So when you look at these 3 scores, you will see that the higher the score, meaning the more deranged a parameter is, the higher the risk of this patient having a poor outcome, and the higher the risk of this patient deteriorating very quickly. So you relate the score to guidelines. Depending on the score, you'll be able to ignite or institute a particular response. And these responses may, for example, include calling for senior help. It may be calling for what we call a response, rapid response teams for those facilities or hospitals with established rapid response teams. It may involve calling what we call an emergency response team or a code blue in severe cases if it's a cardiac arrest. Another action that can be elicited by the scoring systems would include calling for expert help or specialist help, for instance, or maybe for that patient to a higher level of care. So that's the importance of these scoring systems. So the other scoring system that can be used is the modified early warning score. So the early warning score has also undergone various upgrades, and the current one and the most simple to use is the modified early warning score. And this one also gives us, it can be applied to all patients in different setting. It can be in an emergency setting, it can be in an ICU setting, in a general ward, where you'll be looking at a certain set of signs, you calculate the score, and depending on the level of that score, you also provoke a particular patient intervention. So the modified early warning score also has been very useful because it uses the very simple vital signs or parameters that we use, that we normally do on our patients. For instance, it will look at the systolic blood pressure, the heart rate, the respiratory rate, the temperature, as well as the level of consciousness of the patient using the AVPU scoring system. So each of these parameters is given a score depending on the degree of derangement, and then the total score is calculated, and then that score is now compared or assessed to see what sort of appropriate response needs to be instituted for that patient. So this score can be used in the emergency setting, in the triage areas, in our general wards, as we monitor these patients' vital signs. The last scoring system I'll quickly talk about is a QSI scoring system, which is a quick COVID-19 severity index score. So this score is specifically designed or established to sort of predict the 24-hour risk of respiratory deterioration. I would like to ask Sarah just to click on the details so that our participants can appreciate. So again, kindly feel free to refer to our resource centers for more details. So you will see that this quick COVID-19 severity index score uses only 3 respiratory parameters. So you'll be looking at the respiratory rate, you look at the SpO2, and then how much oxygen in terms of flow rate that you are giving to the patient. And then you score appropriately based on your parameters. Once you add the totals, you will now correlate with what sort of interventions would this patient need at that particular score. Certain scores are actually in the red flag, and so you need to really escalate the level of care of this patient, including transferring that patient to an ICU. So you'll be looking at these 3 parameters and then getting the score of each of those parameters, total them up, and then look at what the total score means. So the higher the score, the higher the risk of deterioration for this patient, the higher the risk of respiratory failure, and the higher the chances that this patient may require advanced or high level care. So as Sarah, we can go back to the original slide. Yeah, so that's just about the different score systems that we can use in our various health facilities to help us, give us a guide and trigger a particular intervention. And the good thing is these scoring systems are very simple. They are based on very, very basic parameters, very basic vital signs, and then they'll guide us on what appropriate action to undertake. This also, the scoring systems can be done in addition to our clinical judgment. So they will not replace our routine clinical judgment on the condition of the patient, but they would augment, and they would also become much more helpful if the person who is looking after that patient may be a nurse, a critical care nurse, maybe a clinician, and so it will help them to make an appropriate decision based on what the scoring systems look like. So if there are any questions, please feel free to drop them in our chat box there, and then we'll address them. So the next session, we'll be looking at defining rapid response systems, which is one of the possible interventions that we can institute based on the scoring systems that we've just discussed about. So the practice change items here would be to outline the life-threatening signs and symptoms indicating patients need time-critical care. So going further down our case, So this patient now suddenly loses consciousness, and the new set of vital signs are as follows. So the respiratory rate goes further up. It's now at 40 breaths per minute. The temperature is at 39 degrees Celsius. The heart rate has gone up to 147 beats per minute. And then the non-invasive blood pressure has dropped further down to 63/25. And the oxygen saturation also has dropped further down to 66%. So the question to look at now is that for this patient, what vital signs or clinical exam findings require immediate intervention? What vital signs or clinical exam findings require immediate interventions? So as you look at these parameters above, or the vital signs that we have, which ones would indicate that this patient requires immediate intervention? So I would like Sarah to click on the details. Yeah, so I would like us to answer that question by relating those vital signs to a guide that we can actually use to help us determine which parameters are normal and which ones are abnormal, as well as know at what threshold should we institute a particular response. So when you look at the patient's heart rate, so the patient's heart rate is high, and then we have a guide here that the heart rate of about 40 or a heart rate of less than 40, this in itself sets an alarm. So you need to institute a particular intervention. It may be calling for help, it may be activating the rapid response teams, etc., etc. If you have a respiratory rate of above 28 or less than 8, that is also a red flag. You will need to call for help or activate certain interventions before the patient deteriorates further. So the other parameter is your systolic blood pressure of above 180 or less than 90. That should provoke a response from the clinical care team. SpO2 of less than 90, I think Dr. Piri just defined what normal SpO2 is and what appropriate actions to take. So an SpO2 of less than 90 means that the patient would need particular interventions such as oxygen delivery. Other triggering points would include acute change in the mental status of the patient. For instance, this patient that we have has suddenly lost consciousness, and that in itself is a very, very important sign for us to institute a particular measure. Urine output of less than 50 mL over 4 hours, as well as any concern from a staff member over the patient's condition, that should also help us trigger a particular reaction. So when you look at all these triggers here, you would see that our patient's vital signs are severely deranged. The respiratory rate is 40, it's very high. The temperature is 39 degrees Celsius, very febrile, and the heart rate is 147 beats per minute, extremely high, and the blood pressure, the systolic, is 63. So this patient will actually need some kind of intervention at this point. And I think one of the aspects we'll discuss now is to look at the rapid response teams and the code below. I don't know if there are any further additions from my co-panelists regarding the section.
Okay.
If there's none,
Dr. Spuka, just before you go ahead,
Yes.
I just wanted to mention one thing. You took us through 3 scoring tools, which can help us to make a clinical decision, and you've gone into the actual change in vitals. I just want you to make a comment on which one you would prefer, especially dealing with our COVID-19 patients. What is easy to use? What have you found useful in your own practice? And then I just wanted to put everything together. I think when you have all of these vitals in critical care and you put them into a scoring tool, it becomes easy to track as to whether your patient is improving or whether they're deteriorating. And I would encourage every one of us to use some type of a score from the admission from admission point throughout the hospital stay up to the point of discharge of a patient. It makes the care of a patient so much easier. But which scoring tool would you recommend?
Yeah, I think the thing with the scoring systems is that they really vary from institution to institution. We've seen various institutions adopting their own scoring systems based on their local scenarios, local availability of resources, et cetera, et cetera. So they are not really a standard. It's just a guide. Next one, well, it really depends on what their local hospitals or their local institutions agree upon. But looking at these 3 scoring systems, there are so many, by the way. You have things like the Papytcho scoring systems, which we out of the scope of this discussion, there are so many of them. So looking at these 3 that we have here, really, they are basic scoring systems. You don't need any sophisticated equipment. You only need vital signs and a few basic clinical signs. The Q-SOFA scoring system is very, very simple because you're talking about basic parameters, the altered mental state, your systolic and the respiratory rate. This one can also be very, very useful, especially in outside ICU settings. So it can still be used. And personally, I think I found this very, very useful because it works well in a setting that's outside ICU. The meals as well, when you look at the parameters that are considered in the meals, are very, very basic. It's the vital signs that we do every day, the BP, the respiratory rate, the SpO2, just those basic parameters. You calculate a score, and then a guide is given on what appropriate interventions that you need to institute at a particular score. Some of them you just aggressive or monitoring. Some of them will just require you to call a senior help, a clinician's review. Others will be as high as requiring you to activate what we call the code blue team if it's a cardiac arrest. The QCI score is also another basic tool. Really, these scores are something that can be adopted in any institution. And like I said, I think various institutions have used different types of scoring system. I would actually recommend all of them, but they should apply in an appropriate setting.
Okay.
Thank you, Dr. P.
Okay, thank you very much, Dr. Spoka. You can go ahead.
Yeah, so the next question is, which of the following interventions may be needed for this patient? Which of the following interventions may be needed for this patient? Looking at the above presentation, the current scenario, and the above vital signs that we have, which of these interventions do you think would be appropriate for this patient? So kindly feel free to drop the responses in the chat box so that we can discuss maybe in a minute or so. What are some of the interventions that you think should be instituted for this patient at this stage? So maybe under a minute or so, we'll get back together and discuss.
Okay. Sarah, can you please poll for us? I think there's a poll just below. Can you just poll for us?
Yeah.
Yes, we're working on it.
Yeah, I can see that we're already getting some responses. Okay, well done.
The poll is launched.
Yeah. So we are getting responses. Okay, so in the interest of time, Sarah, you can show us the total poll. So I can already see that most of our respondents and participants, they've chosen the last response, the last option. So all of the above are interventions that are required at this stage. That is the correct answer. So this patient, when you look at the vital signs and the clinical picture, this patient will need a higher level of care. It might be a high dependency unit. It might be an intensive care unit, depending on what is available at your facility, but they will need the highest level of care. They will definitely need oxygen therapy because look at the oxygen saturation is very, very low. They will probably need a higher and more aggressive oxygen therapy. And then they need frequent monitoring. So this is a patient who is critically ill, so they will need to be monitored for all the vital signs. They will need to be resuscitated, and resuscitation should be ongoing as we monitor the patient closely. They will need airway management or airway support because this is a patient who has suddenly become unconscious, and so we need to manage the airway as we also deliver oxygen. So all of the above interventions should be administered in this particular patient. Well done to all of those who went for the correct response. Thank you.
Okay, Dr. Spuka, thank you very much for that segment in the discussion. Before we go into our breakout rooms, I just want to know how many of us have got rapid response teams or code blue teams or any type of system in our hospitals who we can call in the event of a patient collapsing. Please participate in the polls. At this point, I am going to ask Unish to break us into 3 breakout rooms. We'll be there for a good 7 minutes. Please, moderators, I think one group will be led by Dr. Spuka. One group is going to be led by Dr. Papytcho, and then I'll be leading one group. So please appoint a secretary who is going to take notes and then tell us what you discuss when you come back to the main group. So I'll lead the group talking about the activation of the rapid response teams. Dr. Papytcho, please talk about the activation triggers, patient triggers. And then Dr. Spuka, in your group, please talk about some of the steps. What can you do to create a rapid response team in your facility? Please talk about the importance of and some of the SEDA principles. So I think 7 minutes, and then we'll have 3 minutes to report when we come. Sarah, do you want to talk about the rules for the breakout rooms? Sarah?
We can just go ahead into the breakout rooms.
Okay.
Unish, you can go ahead and launch them.
Now you will be just receiving a request now and just clicking on OK, you will joining the room. Thank you.
Okay, thanks, Unish.
Hello, good afternoon, everyone. And welcome to this breakout session. Can you all hear me?
Yes, can hear you.
Yes, you're loud and clear.
Okay, thank you so much. So I would like to choose one person from this team to be our recorder, and then when we get back to the main group, that person will actually give us a summary of some of the things that we have actually discussed. So I would propose Gideon Chongo. Gideon, are you there? Gideon? Gideon, are you there? Okay. Gideon,
Yes,
can you unmute?
Hi.
Okay. Okay, great. Kindly be our recorder just for some of the things that we'll discuss, and then we'll summarize it together on the main platform.
All right.
So
that's fine.
Yeah. So we've broken down into three groups. The first group will be talking about activation of the rapid response teams. So we actually talking about the rapid response teams and how we can go about setting up the rapid response teams in our various hospitals, various health facilities. So the first group will be talking about the activation of these rapid response teams. The second group will be talking about patient triggers for the rapid response teams. And then the third group, which is us, will be talking about implementation of the rapid response teams. I know that most of our facilities, we do not have these rapid response teams, but it's a very good initiative because it has worked very well in other centers. They've been able to reduce a number of mortalities, reduce a number of morbidities and other poor outcomes. So we'll be talking about implementation of the rapid response team, which is something that I want to encourage us to consider setting up in our various health facilities, as it has been shown to improve outcomes in critically ill patients. So I would like to take you through some of the principles for setting up rapid response teams. We have a mnemonic called SEDA, S-E-D-A, SEDA principles. So the first S is the situation. The E is evaluation, and the D is decision making, and the A is action. So these principles guide on establishing these rapid response teams. So I'll quickly talk about the situation. When are we talking about the situation? First of all, we need to recognize the importance of these rapid response systems and teams. We know that rapid response systems, they improve patient outcomes. They identify early warning features before a patient deteriorates further into, for instance, a cardiac arrest or a respiratory arrest. And then the other thing is that they also provide a time critical care to unstable patients. So they help in quickly escalating the level of care of these patients who are deteriorating. So that's the situation. Under evaluation, as we are setting up the rapid response teams, we need to create a rapid response team policy document, okay, for the institution. We'll briefly talk about this. So you need the rapid response team policy document. You need to identify key stakeholders of this team. Who are the main, which people would you like to constitute the rapid response team? For instance, you can have nurses, you can have physicians, you can have pharmacists, you can have respiratory therapists, the people that you think will be key in forming these rapid response teams. Then on the third point is D, which is decision. So you need to form a rapid response team committee, okay? Ensure that each of the members of that team have got specific responsibilities, okay, that are assigned depending on what role they play. Then the last one, which is action. Action is you need to adapt the existing protocols to the institutional resources available, okay? So that is the SEDA principles that we can use to actually come up with the rapid response team so that we improve our mortalities in our hospitals. So remember, one of the key things is that training is very, very important as you set up these rapid response teams, because you'll be dealing with emergencies. And the specific form of training that is important is simulation training. So simulation training has been found to be key in actually ensuring the effectiveness of these rapid response teams that we set up, because you know simulation training is practical, it's experiential, it's a real life kind of situation. It's practical in nature and it's hands-on. So through simulation trainings, you bring in reality, and so at the end of the day, you have a very effective and formidable group forming the rapid response teams. So what are some of the steps? What are some considerations that we can make as we create these rapid response teams? So the first thing is we need to create a rapid response policy document for the institution, okay? So what do you think are some of the components of this document? What would you like to include in the document? Can anyone just give us a quick run? What are some of the things that you think the document, the rapid response policy document should include? I think we've discussed some of them earlier. Anyone? You can kindly unmute and then you make a comment. Okay, so yes.
Dr. Spoker.
Yes.
Well, here.
Yes, John.
I would like to contribute looking at what we have discussed so far. I think in this rapid response document, we need to include the names of the individuals that will be involved in the whole system. For example, if we say we put in the nurses, the physicians, the pharmacists, the physiotherapists, we need to specify in terms of naming them.
Okay.
And also have their phone numbers well documented.
Okay, great. Thank you so much. I think that's a very valid contribution. We need to identify the different players in the group by name, phone number, and even address, so that it's very easy to activate or to call upon them whenever there's an emergency. So we also need to create an alert criteria or triggers. Okay, we need to create certain parameters, guidelines on what parameters, what criteria should trigger the use of a rapid response teams, meaning that this will be who to call, how do they call, who responds, and who are the members of the rapid response teams, what expertise they will bring.
Code blue team. And I think certain hospitals are doing it, except that maybe it's not very effective because I think you need some certain equipments like beepers, or a hospital to be like to have a intercom installed so that when there's an emergency in a certain department, they call upon them so that they can rush to a place or a ward that has that emergency.
Okay.
But it is very feasible. Yeah.
Okay,
Sorry to
Richard,
interrupt
thank you.
you. Sorry to interrupt you. The peoples are joining back and the breakout room has been finished.
Okay, thanks, Sunish. Richard, please give the response when you're called upon for breakout room. Is that okay?
Thank you.
Okay. Sarah, can I please have the whiteboard up?
Yes, if you share screen, there's a, do you want me to write on the whiteboard or do you want to write on the whiteboard?
I think you can write on the whiteboard.
Oh, I see. Yes, got it.
Okay. So at this point, before we begin to give a recap of what was discussed in our breakout room, I would invite Dr. Spuka from the third breakout room to tell us about the SEDA principles and the importance of simulation, and then he'll give a feedback on their discussions. Dr. Papytcho, you talk about your patient triggers, and then breakout room 1. Richard, you give us the recap from that breakout room. Dr. Spuka, breakout room 3.
Okay, thank you very much. So I would, our discussion breakout session was looking at the implementation of the rapid response teams. And so we discussed the SEDA principles, and I think I would call upon Gideon Chongo just to give us a summary of some of the things that we discussed. Gideon, are you there?
Yes, I am. So looking at the importance, initially we're looking at implementation of the rapid response team, and looking at the importance of these teams in timely management of patients and escalating care. So we have to implement them. So under the implementation, that's where we talked about the SEDA principles. And these SEDA principles actually stand for different things. The letters there stand for different things. So S stands for the situation, and then E stands for evaluation, and D stands for decision making, and then A stands for action. So under these SEDA principles, so what is included, or the most important thing initially, is to actually form what is called a rapid response team policy document. This is where guidelines to trigger rapid response teams, or what is in the policy document, is actually going to be undertaken. So it's important that in these documents a committee is formed, and in this committee, the committee seeks to identify individuals that are going to be involved once this rapid response team is activated. So the specific individuals, their phone numbers are going to be written there, so that if we need to implement the rapid response team and what is contained in the policy document, these individuals are contacted, and then this can be activated. So under the action, we did talk about adapting. That it means that we have to adapt existing protocols that we have actually in the policy document to the available resources under the ground. And under here, it is very important that we make simulations. So simulations are prepared well in advance, so that if we have a situation, then the SEDA principles can be followed like that, and the individuals born, and the implementation of this rapid response is actually achieved. Maybe Dr. Spuka can help me with the rest of the, if I've left anything.
Okay, well done, Gideon Chongo, for that. I think you've touched on most of the items that we actually discussed. So, and I just want to quickly mention that these rapid response teams in institutions where this has been very well established, they've really been shown to reduce mortalities and improve patient outcomes. And the process of setting up these rapid response teams is not a very complicated process. You just need a few guidelines, and this is where the SEDA principles of setting up the rapid response teams comes out. You look at the situation, the relevancy, the importance of these teams. You look at the evaluation. How are you going to evaluate? What are some of you come up with a policy document that will have all the guidelines and establishment and the terms of reference for this particular rapid response teams. And then the other key thing, like Gideon has mentioned, is simulation. So simulation trainings have been shown to be very, very effective way of training, especially in handling these emergency situations, because simulation trainings are practical, they are hands-on, they are experiential, they give you a real life feeling of how it would feel like or look like when an actual emergency actually happens. So you do simulations on things like cardiac arrest, airway management, patients whose vitals are crashing, cardiac arrhythmias, hypoxemia, hypoglycemia, altered mental state. So you can simulate on all those medical emergencies as you actually prepare these rapid response teams and making sure that they are effective whenever they are activated. No, thank you so much, Dr. Chong, for that summary. I'll hand it over to Dr. Piri.
Okay, Dr. Spuka, thank you so much to you and your group. Quickly, Dr. Papytcho, can we have feedback from your breakout room?
Thank you very much, Dr. Hope. Thank you very much, Dr. Sipuka, for the nice discussion in your group. As we discussed, patient triggers for activation of a rapid response team. Unfortunately, the discussion was so nice and then the timing was too short. We should have maybe taken like 30 minutes or so. So yeah, but we managed to discuss on one or two things. For this, I'll call upon Grace, who's our rapporteur, and then she'll come on the floor and tell us what we discussed. Hi, Grace, are you there? Okay, Grace sent a message in the chat box saying she could barely get us because her network was poor. Now, Grace, come on the floor and say what you read, and then we'll complete you as we discuss further. What you read, you can just say it, and then we'll discuss further. Oh, Brian, can you take it up?
Though I was not documenting anything, but I think I can take it up from what I could get. I was having at some points when network was a challenge. But anyways, I think the first thing we discussed was when do we trigger, or when do we call for help, or when do we call the response as a team? So the first thing was when we have RTAs, when you have an emergency, you can also call for trigger the rapid response team. And then in what situations do we call for a rapid response team? Things like obstetric emergency, maybe neonatal resuscitations, we can trigger the team to respond, or any critical emergency which needs the attention of the team, we can trigger that. In terms of air emergencies, bleeding, and the like. I think those are a few things I got, unless the additions from the team. Thank you.
Okay, thank you very much, Brian. In the interest of time, I'll come up and add on a few more things. What we discussed is that first, the trigger can be sent by a trained medical staff or a non-medical staff. Anyone who's at the site when the event occurs can still call upon a rapid response for them to come and deliver the better services to optimize patient condition. And then, depending on institution, the triggers can be classified in different groups. You can put them as the hospital protocols, whereby you say, in our institution, when you look at the vital signs, so meaning first group looking at the vital signs, if the vital signs, they go below or above these figures, a rapid response team can be triggered so that the right team can come and evaluate the patient for them to take up on a better decision, either to escalate the care to another environment, or just there, they can give advices on how to take care of the patient. Another way of looking at the triggers, it can be based on the signs or symptoms that the patient can present. A patient can have like chest pain, radiating chest pain, that looks like MI. A patient can have things like seizures, patient can convulse, and then a trigger can be sent along so that the right team can come and review the patient, or the glycocomas of the patient can suddenly drop. Patient was talking to you and then become unresponsive, and then you have to do what is ideal for that patient condition to be reevaluated very fast and taken up in a better environment for better care. The last group of conditions that we looked at, we said a trigger can be based on the diagnosis. A patient who comes with sepsis, with arrhythmias, acute asthma or COPD, acute all those pulmonary edema, pulmonary embolism. Such condition can also be used as triggers for them to call upon a rapid response team. So it must depend on hospitals, what they think they can make up as a trigger sign for them to call up a rapid response team so that they can come and take good care of the patient. Thank you.
Okay, thank you so much, Dr. Papytcho. From breakout room 1, I'll ask our secretary, Richard. Richard, can you just go through our discussion?
Okay, thank you very much, Doc. So in our breakout room, we looked at the composition of this rapid response team and the code blue team, who triggers or who cause for an emergency. So we looked at the two limbs of a rapid response team. Okay, one which is the person that is calling for an emergency. This can be a person that is there when this emergency is happening, when this patient is deteriorating, or the nurse that is taking care of the patient. Okay, and then the other limb, we looked at the one that are responding, the people that are composed in this code blue. Okay, so we also looked at the composition of this team, who are supposed to be found in this code blue team. So we said that there should be an emergency physician, a critical care team, or an emergency care nurse, okay, who are able to respond to the emergency or when they're called upon. Okay, so we also looked at the department being when they call for an emergency. No, it should be like in a situation where they are able to do something before the team comes to like take up the care or to move the patient to a high dependence department or unit or to the ICU. Okay, so we also looked at, yeah, I think those are some of the things that we discussed in our breakout room. I don't know if Doc has something to add up. Thank you.
No, Richard, I think you've said it well. I think we discussed the two prongs of the rapid response team. We've got the afferent limb and the efferent limb. The afferent, we're talking about the personnel calling for the code blue team, and then the response is the efferent team. So we looked at the personnel in both teams and who could trigger. In the afferent, it could be the patient, the family members, the critical care team, or it could also be the nurses who are looking after the patient, clinicians and physicians. So it depends on the level and the type of ward and setup. But basically, you're calling for help, you're calling for people who are going to give you a bird's eye view on the patient's care, and then they'll add to what you're doing. In terms of preparedness, departments should have a crash cart or an emergency trolley, which should be prepared and checked all the time, so that if a patient deteriorates and the code blue team is called, everything is in order and we don't need to start scrambling around. So I think in a nutshell, this would conclude our discussion points for today. I'll just ask Dr. Papytcho and Dr. Ndaba to come forward if you've got any remarks or additions before I give the conclusion for today's. Dr. Ndaba.
Okay. Thank you very much, Dr. Hope. Yeah, let me do mine quick. Thank you, SPK, for giving me time to carry on. I think we discussed broadly what is a rapid response team and what are the challenges that we can face in a different institution. But I think what matters is how to sort out the challenges. For us to be able to implement this effectively, we have to involve even our administrators. If we leave them behind, they might not give you enough support. And remember, you also need a quality improvement team to assess you to see if you are really doing the correct things. What is the impact of the rapid response team? So when we go back in our institution, let's go make teams to see on how we can implement this so that it can be very useful at any time. Thank you.
Thank you, Dr. Papytcho. Dr. Ndaba?
Yeah, thank you. Thank you very much. Well done to everyone. Great participants. Yeah, so I would like to encourage our participants once again to visit the Learning Resource Center for all these discussions and for all the other details that we may not have covered due to the interest of time. There's a lot of material, there's a lot of data that you would be glad to just look through all the early warning scores, how to set up a rapid response team, some of the guidelines, some of the triggering factors and things like that. You will all find them on the resource center. And then early warning scores have really been found to reduce mortality and improve patient outcomes in centers where they've been used effectively. And I would like to encourage our participants to look at these scoring systems, okay? These scoring systems are very, very simple. We can redesign and readapt them to our settings to meet our standards so that it helps our nurses, it helps our clinicians, especially in the emergency departments, in the triage areas, in the COVID centers where they receive and treat these patients. Some of them may be severely sick or critically ill. They'll act as a guide to trigger a particular response. So as we go back to our facilities, we can actually inspire some of these changes, including a rapid response team. Thank you so much, Dr. Piri. Over to you.
Okay, thank you so much, everyone. I'm aware that we've gone a good 20 minutes above the 70 minutes that were allocated. Thank you for staying with us up to the end. I think I just want to emphasize what my co-panelists today have talked about. The two concepts that we've gone through. We've gone through the oxygen escalation ladder and the cautious use of oxygen in patients, acutely ill medical patients. We've gone through scoring tools and developing or talking about developing the agenda for rapid response teams. So these are potential quality improvement areas which we could take up in our own space. The SEDA principles teach us that we cannot change all the problems which are there in our hospitals, but we can at least try to implement changes which will have an impact within our work areas and workstations. So using the SEDA principles, we're able to achieve that. Please, for those of us who joined in through the link which was shared via the various social media platforms, this is a recurring link. Please add it to your Google Calendar and you'll be able to get a prompt the day before and a few hours. Just to go through the key principles for today, we looked at the continuum of care in critical care, that it's just not limited to ICU, the prudential use of oxygen and the oxygen saturation target in acutely ill medical patients, the use of the clinical scoring tools to guide our therapy. We also looked at the importance that the rapid response teams bring to our critical care teams. We also need to know who should activate and who should respond to a code blue team. As a hospital, as healthcare workers, we all bring different skill sets to the table. And once we learn to call upon each other in times of emergencies, we're able to come up with a cohesive team in terms of rapid response by putting our skills together. And lastly, we need the support of our administrators. We need policy documents in our hospitals to make sure that everything that we practice is in line with our hospital protocols. Documentation during a transfer is very important due to the medical legal implications that are there in healthcare. I think in a nutshell, those are the key learning objectives to direct our practice change behaviors from this lesson. Sarah, I'll hand over the floor to you. Please give us the closing for the session.
Yes, thank you, Dr. Hope, Dr. Papytcho, and Dr. Sipuka. That was a very excellent presentation. Just to close us out today, if you would like access to any of the materials that were shared today, everything is on the Learning Resource Center. For free, you just need to create an account, and we've dropped the link in the chat as well. If you would like to join our WhatsApp group for updates and to stay connected, you can scan this QR code here or message Assist International at this number below. Thank you for joining us today for this very excellent, very informative session. Our next session is on June 17th. Session 6, which will be basic ICU care considerations. If you have any questions, please feel free to email us at echo@assistinternational.org. And we would like to thank our sponsors for today's event, Echo India for supporting us and the funding, Assist International, Stanford for creating all the materials, and then UNM. Again, thank you for joining. Thank you to all of our panelists, and we look forward to seeing you next session. Have a great one, everyone.
Okay, see you on 17th June, everyone. Bye-bye.
Thank you, bye-bye.
Bye, thank you.
Bye.